Hi, my name's Vanessa, and the intervention I've chosen is the management of schizophrenia with pharmacology. The reason I chose this topic is that I work at the Mental Health Assessment Unit in the ED department at the Canberra Hospital, and we often see patients who are diagnosed with schizophrenia who have relapsed. This may be due to various reasons. My interest is in the effectiveness of antipsychotic treatment for the management of people who are diagnosed with schizophrenia. I'm also interested in the guidelines and recommendations that govern this. Schizophrenia spectrum and other psychotic disorders are defined by the American Psychiatric Association as abnormalities in one or more of the following 5 domains: delusions, hallucinations, disorganized thinking, grossly disorganized or abnormal motor behavior, as well as negative symptoms. Psychopharmacological interventions are used to reduce these symptoms. In a quote cited in Emsley 2013, schizophrenia is defined as a chronic and disabling illness with the majority of patients experiencing multiple relapses during the course of the illness. Relapse is characterized by acute psychotic exacerbation, which may have serious implications. For example, there is a risk of patients harming themselves or others by jeopardizing personal relationships, reputation, education, and employment status, and of further stigmatization of the illness. There also is a biological risk. It has been proposed that active psychosis reflects a period of disease progression insofar as patients may not return to their previous level of function. The search engines that I used to find journal articles was the Cochrane Systemic Review database, the Cochrane Schizophrenia Group database. I also looked in the University of Canberra library database. The search words that I typed in was schizophrenia, relapse, relapse prevention, and maintenance. I also put in the search engine journal articles published from 2011 and 2015. By using these search methods, 3 articles were found. The first article that was found was by Leach C. et al. 2012, which is looking at antipsychotic drugs versus placebo for relapse prevention and schizophrenia, which is a systemic review and meta-analysis. The second journal article that I found was by another Leach et al., which was looking at the comparison of oral antipsychotic medications versus depot for the treatment of schizophrenia. This was also a systemic review and meta-analysis of randomized controlled trials. The last journal article that I found was by Takeuchi et al. 2012, which looked at management of antipsychotic treatment for schizophrenia in the maintenance stage, and this was a systemic review of guidelines and algorithms that were already published and used in clinical settings. The first article was antipsychotic drugs versus placebo. The outcome measurement was participants who had relapsed, required admission to hospital after given either the antipsychotic or the placebo. Random control trials that compare the effects of a group of individuals adhering to the drug regime versus the control group. The antipsychotic drugs that we used include chlorpheniramine, fluphenazole depot, haloperidol depot, quetiapine, paliperidone, mixed antipsychotics, and zyprenosone. Level and quality of evidence. This is a systemic and meta-analysis review of randomized controlled trials that compared maintenance management of patients with schizophrenia with the use of antipsychotic medications and a placebo. The level of evidence was identified as level 1 in accordance with the NHMRC evidence hierarchy. The study managed to find 65 randomized controlled trials with a total of 6,493 participants. The study selected trials with adequate randomization and allocation concealment methods. Vigorous appraisal of eligible studies were conducted to identify bias and ensure quality. A range of models were used to identify the risk of bias amongst the selected studies. The use of the Cochrane Collaboration's risk of bias method was used to assess quality of sequence generation, allocation, concealment, blinding, missing outcomes, selective reporting, and other biases. Heterogeneity was assessed by the Durst, Simon, and Lard's random efforts model and meta regression analysis. Different relapse definitions and drugs in early studies led to heterogeneity. Publication bias was assessed with the use of a contour-enhanced funnel plot and the trim and fill method. The funnel plot was proven to be asymmetrical, and the trim and fill method only resulted in slight reduction. Therefore, publication bias was not suspected. Potential biases due to poor adherence to the Consolidates Standards of Reporting trials, or CONSORT guidelines, was investigated. However, there was no evidence in subgroup and sensitivity analysis for randomization and allocation concealment. It was found that definitions of relapse varied. 26 used clinical judgment, and 17 the need of medication. 15 they used a rating scale definition, and 3 studies used an admission to hospital as a relapse definition. 2 dropped out of the study as symptoms became worse, and 2 had unclear methods of defining relapse. 19 studies used mixed groups of antipsychotic medications, and others used single drugs. In 11 of the trials, all patients were in remission at baseline. 8 trials included results from the first episode groups, and others did not. Findings of this study showed that antipsychotic drugs significantly reduced relapse rates at 1 year. They showed 27% taking the medication relapse, as opposed to 64% who relapsed taking the placebo. They showed that fewer patients given antipsychotics were readmitted, 10% versus 20%, but less than a third of relapse patients were readmitted. The next study was oral medications versus depot. Non-adherence to antipsychotics treatment is identified as a major problem. This study aims to identify if antipsychotic depot formulations reduce relapse. The level and quality of evidence. This paper identifies 10 randomly controlled studies that were systemically reviewed. The level of evidence in accordance with the NIHR-MC levels of evidence is level 1. 1,604 participants were included in this study. 55% of them were male. In terms of bias, the Cochrane Controls risk of bias was used with respect to randomization, allocation, blinding, data completeness, selective reporting, and other biases. Lech et al. 2012 identified that 3 studies described randomization methods, 3 were open, 2 were single blind, and 5 were double blind. Heterogeneity was explored using a chi-square test of homogeneity together with the I-squared statistic that considered values of 50% or higher to reflect substantial heterogeneity. This showed heterogeneity in relapse, rehospitalization, and non-adherence. Publication bias was also investigated, and this was done by using a funnel plot. However, this was not suggestive of bias. Different antipsychotic medication was used in different oral form versus depot form. And bias was also in procedures and trials that may have influenced adherence to treatment, such as trials that have home visits or when patients had missed their medication or they would get a phone call as a reminder. And overall, this would affect the dropout and relapse rate. Details about methods of randomization, allocation, concealment, and blinding were not presented. There were lack of blinding trials comparing depot and per oral medication. 2 studies excluded non-adherent patients. In one study, adherence was improved by a nurse being available by phone 24/7. And side effects beyond dropout rates were not explored. This study found that 21.6% of participants in the depot group relapsed compared to 33% in the per oral group. So that shows a substantial amount of people relapsing on oral medication as opposed to depot. 7 studies with 1,476 reported the need for hospitalization due to relapse. There was no significant difference between the groups. There was no difference in the numbers dropping out for any reason, and 5 studies reported some information about adherence. Antipsychotic treatment in the maintenance phase for patients with schizophrenia was the last journal article that was found. The purpose of this systemic review is an overview of the recommendations for antipsychotic treatment for the maintenance of schizophrenia in various guidelines and algorithms. 14 guidelines and algorithms were identified, and they were published by huge professional clinical bodies, such as the American Psychiatric Association, Canadian Psychiatric Association, Ministry of Health, which is in Singapore, NICE Guidelines, which is the National Institute of Clinical Excellence, as well as the British Association for Pharmacology. And other quite large organisations, Texas, the World Federation of Societies in Biological Psychiatry, as well as the Royal Australian and New Zealand College of Psychiatrists. So the level of evidence in accordance with the NHRMC levels of evidence is level 1, as this is a systemic review of 14 guidelines and algorithms, and they were all informed by individual randomized studies. Each guideline and algorithm was investigated in terms of recommendations on antipsychotic discontinuation, intermittent antipsychotic therapy, dose reduction, and dose range. Through investigation, they discovered various inconsistencies, and this is in regards to the recommendation of dosing. Definitions were different, and only 5 of the 14 guidelines and algorithms explicitly defined terms about maintenance phase. Individualized randomized studies informed the presented guidelines and algorithms, but were noted to be of too short a duration for this chronic condition. Takeyuchi et al. 2012 found that recommendation on dosing reduction was not certain either. The duration of stability in each was vague also. So the findings. 10 articles did not recommend discontinuation of antipsychotics. 6 articles supported ceasing antipsychotics in patients with first episode schizophrenia. 9 articles mentioned intermittent or targeted strategies and did not endorse these. 11 articles mentioned dosing reduction. Guidelines made different recommendations for dose range. The study concluded that further evidence is needed in order to guide optimal antipsychotic therapy for patients with schizophrenia who are in the maintenance stage of treatment. And this is quite unnerving. So to summarise the lessons that were learnt from doing this assignment, it was quite difficult to find recent systemically reviewed articles. Maintenance treatment with antipsychotic drugs do benefit patients with schizophrenia. Advantages of these drugs should be weighed against associated side effects, which were not addressed in that article. Future studies should focus on long-term morbidity and mortality on these drugs. Depot antipsychotic medication was shown to significantly reduce relapse. And further evidence is needed to inform treatment recommendations on antipsychotics for maintenance management of people with schizophrenia. Thank you for listening to my presentation. This is a reference list. Thank you for listening to my presentation. Hopefully you enjoyed it.